here tonight and taking the evening to find out about Denver Recovery Group, what we do, and hopefully we'll be collaborating with a lot of you in the very near future. So, and thank you to Building Hope, who did a lot of the legwork to put this together. And in my opinion, that's super hard. It's like herding cats to get people like us in one room, trying to plan for things like this. So thank you so much. So we're Denver Recovery Group, and we are a medication assisted treatment program. And what's unique about Denver Recovery Group as opposed to some other MATs is that we offer methadone. And the methadone historically has only been allowed at an OTP. So an OTP, you're going to hear, we're going to talk a little bit about acronyms here in a minute. OTP, NTP, OMAD, MOUD, they kind of all mean the same thing, except for what medications are offered. So a narcotic treatment program is registered with the DEA, similar to a pharmacy, to actually be able to prescribe and dispense methadone. So if you hear MAT, sometimes anybody that's a physician, an NP, a PA, or a primary care physician can actually prescribe buprenorphine. Those are some changes that came about last year with the CARES Act. They made it a lot easier for people to access buprenorphine products like Suboxone and Subutex. Unfortunately, not everybody does it still, and there's still a lot of education that's still needed out there. But for methadone, you can only receive methadone at a registered narcotic treatment program. And it's not easy. It's not an easy thing to set up because you have to have a lot of licenses. You have to have a lot of the right people, physicians. There's a lot of training that's involved. And it takes a lot of work to get methadone out into the community. So what is missing a lot of times is access for patients who need methadone. And we're going to talk about what makes it a little bit different than Suboxone. So we're coming out to Summit County, Breckenridge, as a medication unit. It's a little bit different than a regular OTP, except for it's kind of the same. And the reason why I say that is because in January of 2024, SAMHSA put out some new regulations that allow us to do all of the same services at a medication unit that you would do at an NTP. Prior to that, you could only provide medication. So the exciting thing is you don't need as much space, you don't need as much staff on site, but you can pretty much provide all the same care. In addition, some of the SAMHSA changes allow for telehealth inductions. I don't know if you guys know that those are the hardest thing, is to get a patient on methadone, because to get a medical provider on site 24 hours a day is impossible. The only place that you can get that kind of care would be a hospital, right? So now with telehealth inductions, with our 9 programs, actually our 10 programs as of Monday, you can get it. And we'll talk a little bit more about this for 24 hours a day. So methadone. We're going to talk a little bit about methadone, buprenorphine, Vivitrol, and the differences. Jessica's going to walk us through the intake process for Denver Recovery Group, whenever, wherever you want to get medication. What treatment looks like. Lori's going to talk to you about how do people get medication on a day-to-day basis? What does the treatment look like? We get asked this a lot. Do people have to do counseling? Do they have to do these other things? 100%. And we're going to talk about all the services that Denver Recovery Group offers. And a part of a big role of what we do is patient advocacy. Our job doesn't just start and end with providing medication, because there is still a lot of stigma in the community. Maybe some of you have experienced that. Maybe some of you, know people in your community that have experienced that. We experience that with our patients, and a lot of times we have to go above and beyond to educate community members and family members that methadone is a medication. Many of our patients have died several times before coming to our door. And it's really important that people understand that and know that medication is saving their lives. They are 4 times more likely to die without medication on board. And again, talking about the stigma of MAT. So we'll go into detail with that. Our mission is to provide access. So Denver Recovery Group strives not only in talk, but in action. We aren't about just putting methadone, where there already is methadone, but instead, where is it not? And so as a result, we have 10 clinics across the state of Colorado in areas that have never had methadone. Glenwood Springs, Montrose, here in Breckenridge. And then we've got several clinics in Colorado that started with our downtown Colfax location. But in addition, times of access. So at our Colfax location, we considered our hub. Probably in the next couple of months, we'll be going 24 hours. We already dosed till 8 o'clock, and now we'll be dosing to midnight, probably by next week, couple weeks. But we realized that not everybody can get to a clinic between 5 and 8 in the morning, or 5 to noon. They need options, and there is no other option unless you create it. So that's what we strive to do, and we're hoping to do that here. So obviously we have to start small because staff is the key element. But then we build from there, and with our telehealth model, we're hoping to be able to create that access for this community as well. And reducing stigma, that patient advocacy is part of what we do, and we strive to do that on a regular basis. We attend jail meetings, we attend, we work with family members. We have actually a whole patient advocacy form that patients fill out. And if they experience stigma in such a way that we can help them, they fill out the information, they ask for our help, and then we go to work. We recently had a situation where a pregnant woman this was just this week, got out of jail 10 days pregnant and was not given her medication in jail. That's happening live and well today, and so we continue to strive to advocate for our patients. So methadone is a slow-acting long agonist. So the difference between methadone and buprenorphine is simply that buprenorphine is a partial agonist. So if you think about just a jar, an open jar, and you think about putting balls into this jar, right? There's still room in there for more liquid or sand or whatnot. You can still fill the jar, but you can't put any more balls in there, okay? That's buprenorphine. With methadone, you put the balls, you put the water, you put the sand, right? And it fills it all the way to the top. So what happens now when you've got a long-acting opiate on the receptor that somebody's using, like fentanyl, right? It's a long-acting, and people are using a lot of it. So people get addicted very quickly, and they have to continue to use more and more and more and more. That's the tolerance piece. Well, as they build tolerance, the brain basically says, I have to keep you alive. So it shuts down the endogenous endorphin system. So as a result, as the body is shutting down what we produce naturally, methadone is able to fill up those receptors and tell the body that it can heal. Otherwise, if you keep putting a synthetic narcotic on those receptors, the brain has to continue to open up new receptors on the brain to keep them alive. Okay, so that's tolerance, that's withdrawal. And if you take it away, you're gonna have withdrawal because the brain cannot produce that much. There's no way. It can mimic what you're putting into it, not naturally, synthetically. So as a result, methadone helps people get to the actual dose that they need to be at. We call it a therapeutic level. So buprenorphine, the maximum somebody can get to that's equivalent to methadone is 60 to 70 milligrams. Now there's ways to get it above that with split dosing. They've gotten creative with buprenorphine, but the reality is you really can't go above 70, 80, 90 milligrams. With our fentanyl prices and the other opioids that are coming on board, what's that new one called? Starts with an N. Yes, thank you. We're seeing doses of 200 to 300 milligrams. And sometimes that still isn't enough. So there's researchers out of California talking about, you have to wrap the receptor with short acting and a long acting. I anticipate there's going to be more research to come around what's really going to work with fentanyl. But right now, methadone is what people need, and that's what they want. So that therein lies the difference between the two. Buprenorphine, the traditional buprenorphine / naloxone tablet is actually what's called Suboxone. Buprenorphine's the generic, and Suboxone is, it's got a ceiling effect. So it's got it's got a dual active substance called naloxone. So what happens is if you break that down and you try to use it any other way than it's intended, it's gonna put you in full withdrawal. For example, we have to tell people to take it under the tongue, it melts, they sit there for 15-20 minutes, and then they can go about their day, drink water, etc. But if they swallow it, it actually can put them in precipitated withdrawal. That's how it was designed. But again, it's sometimes, it works for some people, but not for everyone. And then Subutex is buprenorphine without naloxone. Subutex is typically used with women that are pregnant. Suboxone is still not approved by the FDA for pregnant women. I believe they're still looking at some research, and I mean, it'll be a couple more years, but I think they're finding that it's not as unsafe as they was thought. Vivitrol is an antagonist, so the active ingredient here is actually naloxone. You use naloxone as a partial sublingual inside of Suboxone. There's also Narcan, the overdose prevention. And then there's naltrexone, which is the pill form of Vivitrol. Vivitrol is a shot that you take once a month, and it actually binds to the receptor and blocks any opiates that can get in there. So people don't actually feel the effects. Unfortunately, they still get the effects. So they may not feel it, so it deters them from taking opiates, and it also decreases cravings. One of the downsides of Vivitrol is people have to come back after 28 days, and a lot of times they don't. So what happens is they run a high risk of relapse, which leads to high risk of overdose if somebody does not return for their shot. And that's the danger of Vivitrol. Research has shown that it's about 20 to 30% effective, but that's in controlled settings. So we offer all three, and we tell people you need medication. We will tell you what we think is best for you, and then you get to decide. So patients always have the option. I think in our settings, it's methadone. They have the option for all three, but methadone usually is what people come to our clinics for. So that's kind of the alphabet soup: OTP, MAT, NTP, OMAT, OUD, MOUD. We are referred to as all of those in federal documents and state documents, but typically what separates us is if you see the NTP, OTP, because a lot of the other providers are also MAT, OMAT, OUD, and MOUD. So OTP is opioid treatment program, MAT is medication assisted treatment, NTP is narcotic treatment program, OMAT is opioid medication assisted treatment, OUD is opiate use disorder, and MOUD is medications for opiate use disorder. But they all kind of are on the same continuum. So we opened up our first location. This is a little history. In 2015 in Denver, Colorado. And since then we have, starting Monday, we will have 10 locations. And once Breckenridge opens, that will be 11. What is a medication unit? Basically, what separates us is that it's just a dosing site, and it's going to be attached to our Lakewood clinic. And we'll do a lot of telehealth counseling, telehealth groups, and telehealth medical appointments at that site, as opposed to having a full gamut of staff on site. We accept Medicaid, Medicare, self-pay, VA, as well as grant funding opportunities. I don't think there's anybody that doesn't have some access to being able to pay for services. And we're open to verify benefits for all other patient private insurance. We really work hard with private insurers, but unfortunately, the downside of private insurance are high deductibles. So what ends up happening is our patients have a $5,000 deductible. Well, self-pay fees are a lot cheaper than paying that before they can get their medication paid for. So we've been trying to advocate for funding for that, and we haven't quite been as successful in that as we want to be. How do we fit with harm reduction? We are harm reduction. We are harm reduction, just as harm reduction is treatment. So we believe we're on the same team, basically. As you can see, the full agonist fits all the way in. Partial agonist doesn't go all the way, and naltrexone covers the receptor.
Okay, so our intake process is as easy as we could make it for our patients. The goal was to just have the patients walk in the door. We know walking in the door is the most difficult part and it's the scariest part for them. So we've created a model where they don't schedule appointments. They just walk in and we help the patient. And that's at all of our locations. Our Denver office is our hub for our intakes, as Denise was describing earlier. So they're open right now, 5 a.m. to midnight for intakes. That is pretty much unheard of across the country. It's something really unique to our company and something we want to expand into a 24-hour model. So from any point in the day, the patient can walk in. It is a very long process for them. It's about 3 hours. They have to meet with a counselor. They do a full clinical assessment, and then they meet with a medical provider. And over the past year, we've really been able to expand our intake process because of regulation changes where we can do it virtual. So all of our locations actually have access to our Denver location to do a virtual intake. And that includes for the medical portion. So even though in Breckenridge we'll probably do 6 to noon for hours, we can still do a virtual intake and then get the patient in. And then of course, if they want to come to the Denver office, if it's later in the day. Across the board, methadone clinics historically have only been open until about noon. Really hard when you have to spend 3 hours at a place if you have a job or if you have kids or whatever, your life circumstances are. So we really wanted to just expand that, break past that barrier and allow patients to come in at any point and do their intake. And that is Monday through Sunday at Denver Recovery Group at our Denver office. We also have another unique thing to Denver Recovery Group that we introduced in the past year, and that's primary care. So our patients face a lot of stigma wherever they go, and that includes their primary care doctors outside of the clinic. So one of the things we've also added is primary care, so our patients can come to our facility, see our doctor for their opiate use disorder and also for primary care needs. We also have a 24-hour intake line, so if anybody ever wants to call for a referral, if a patient has questions, if a loved one, family member wants to call, we have a phone that's carried 24/7 by a staff member. We'll put the phone number up at the end, and anyone can call and ask questions about the intake process, fees, hours for each location, whatever the need is.
Okay, so once people come into treatment with us, we're not a dose and go facility. We believe in recovery as well as sobriety. And so we really try to provide clinical services at the appropriate level to meet the patient where they are in their willingness, ability, to be able to show up for those services and attend groups. We have case management services, we have individual counseling. Like they had said, we have in-house groups at the other clinics, and then we'll have hybrid groups and online groups for people out in this area so they can attend groups and meet with peers that are either where they are, where they were, or where they would like to be. And so we really want to support the community, supporting the community and having those conversations to figure out what works for somebody else, might work for them or might not, right? We do have required groups when they come into treatment. We talk about stigma. We talk about their ability to take out medication, what they need to do to not have to come to the clinic every day because they do want to get back to their life. We want them to get back to a life. And if it was a life they didn't desire before, how can we help them get to a new life, the life they deserve before they fell into the situation that they fell into? And that means a lot for the clinicians that work with our patients, is helping them recover as they're getting sober. We do drug testing throughout treatment. Our facility, our clinics test for, I believe, 78 analytes. You'll go to some methadone clinics and they have you go in a cup and there's 8 little things that they test for in that cup: cocaine, methamphetamine, PCPs on there as a marker, marijuana, alcohol. Buprenorphine's on a lot of them these days. Some of them have fentanyl. We go all out. We want to know what our patients are using, how much they're using. We really love to share with them. Man, this week you went down here. You went up here a little bit. What's going on here? The next week, man, you went down here, but you went a little bit over here. What's going on? So we do regular drug testing on a weekly basis for people coming into treatment. And that's to help give them the feedback from what we're seeing, from all the work they're doing, get into the clinic every day, trying to cut down on their use. If we can get someone from going to 100 pills a day to 50 pills a day to 25 pills a day, that's a win. If that's what they say, they come to the clinic, we don't kick them out. If they keep using other substances, we don't kick them out. That's that harm reduction piece. Again, being attached to a clinic, they're 40% less likely to die. And so we want to work with them, and the polysubstance use, which is meaning using more than one substance, or if they have co-occurring disorders, if they have mental health issues and they're struggling with addiction, we want to work with them on two different levels at the same time. And so it's a parallel process. We'll have case management for people who are just getting into treatment. Maybe they need us to connect with probation, parole, child services, family members. To help support with any community services that they're needing. And then we do get grant funding for transportation. We work with Medicaid and getting Medicaid rides. Medicaid will pay for people to come into the clinic, even if it's 2 hours away and we're the closest clinic, Medicaid will provide those ride services. And so we work with them in a case management perspective. And then we also work with them as counseling, right? Doing treatment plans, 6-month assessments, substance abuse counseling. And we've added another layer because why send someone out if we're convenient for them and they have the relationship and we have the team building that we're providing for them, and we give them mental health services. We have a lot of licensed clinicians and master level clinicians at all of our companies. And so they have a number of opportunities to meet with somebody and get a higher level of care within our walls. I'm a licensed addictions counselor. Denise is a licensed professional counselor, for example. And so as we're bringing people in, we really want to find out what level of care within our company will best support their needs. We do individual treatment planning. They say you only have to do it every 6 months. But that's a long time to wait to figure out what somebody's doing, what's not working, what support do they need, where can they make changes before 6 months from now to get their needs met and to stay ahead of the game. We have so many people that come in and they're motivated and they want to change and they want to be who they deserve to be, not where they ended up landing, right? And so to provide treatment planning, to continue to go over their progress in their use, their progress in their discontinuing use, their progress with getting the job, with getting a new job, with getting reunited with family members who they've disconnected from because they've been in their addiction for 40 years of their life. And so through treatment planning, we're able to continue to meet with them on a regular basis. Our goal is every 3 months to continue to meet with them. And then we also do the 6-month assessments to really help an ongoing process to find out where they're at in treatment and versus where they want to be. Take out medication. Yay. SAMHSA has changed their really, really tight and I think stigmatizing restrictions on people earning takeout medication. And so we are completely aligning with the new SAMHSA regulations. I actually have goosebumps. And we're going to be able to give people takeout medication on a person-centered basis based on what that person is or isn't doing in treatment, right? And if we have someone coming, 2 hours, which we do at our Glenwood Springs location, we have people that are getting rides and they're meeting somewhere and you're getting a Medicare ride, Medicaid ride. 5 people are doing 2.5 hours every single day. Well, let's have them come 3 days a week for a few weeks and see how that goes. And then maybe we can go down to 2 days a week. Before these regulation changes, people had to be in treatment for 90 days before they can get 2 takeouts on the weekend. You can't do it. How do you get a job? How do you get your kids to school? How do you progress in life and enjoy the sobriety that you're working towards if you're really stuck going every single day? And some of the bigger clinics and the hospital clinics, it's not an in and out situation. There's 400 people at some clinics, right? And there's a lot of things that have to happen when they get there. And so for us to have the opportunity now to meet people where they are and to provide them what they need to have to be successful, we're jumping on board and we're getting everything situated to roll that out. And that's really exciting for the community and for the Denver Recovery Group patients. There are states who aren't getting on board. They're going to make people be in treatment for 9 months before they can take home a week of medication. You have to be in treatment for 1 year before you get 2 weeks of medication. You have to be in treatment for 2 years before you can get a month of medication. It's darn near impossible. So we're going to reevaluate everything we're doing and we're going to try to get medication safely into the hands of people on a regular basis so they can continue the recovery portion of their sobriety. Oh man, myths, these are good ones. It gets in my bones. I don't want to get up too high on my dose. There's a lot of things that people are afraid of because of myths and the not just in their home, not just with their family members, but in society, from their primary care doctors, like Jessica was saying. We have a lot of patients that come in, they've already stigmatized themselves. And a lot of it comes from the myths and things that they have. And that's the hardest thing to work through. When someone's looking at you, I'm just an effing junkie, I'm not worth the time. And to convince someone otherwise, that they're a beautiful, amazing human being, and they're worth all the time, is really difficult when they're in that space. And so a lot of these people get stuck just in general with the fear of, I'm gonna get fat, it's gonna get in my teeth. We're trading one addiction high for another. Methadone is a synthetic opiate. It doesn't have the properties to get someone high. If someone is on too much medication, like many other medications, there's negative side effects, like too tired. And that's when you talk to your provider, you back off the medication. It doesn't mean it might not be the stable medication that you're gonna be on at some point. We might have to get you there slower. And so through our providers that we work with, that we have at Denver Recovery Group, they really work closely with our patients. In the beginning, they see them for a week, every single week, once a week. It's called the induction phase. We try to look at that for a 3-month period to really try to get them to a place where they feel stable for 24 hours a day. And that's the goal. If they're still waking up in night sweats, if they're still having restless leg, we need to continue to kind of maybe moving along a little bit and continue to increase their dose so they feel good for 24 hours. They shouldn't have to have any of those side effects. And so a lot of the myths are damning for people who really need to get help and who would benefit from getting on medication to save their life.
I just wanted to add one more piece to the myth. So Denver Recovery Group does a series called MAT buckets. And one of them covers the myths and the stigma. And the reason we do that is because if they can't understand how to talk to people about some of the things that they're told, they never will put 2 feet into treatment. They keep 1 foot out all the time. So we talk to them about how these myths turn to stigma and turn into discrimination. And without their help, there's no way we'll ever debunk the myths. And so we make sure we educate them on how to talk about some of the things that people say.
You, Denver Recovery Group, you guys are awesome. That was such good information.